I appreciate those of you that have joined us, and we're going to get started with the webinar. So we're going to be talking about osteoarthritis of the knee and some options that are advanced in terms of surgical, and then what are the options that are not surgery. You might be surprised to find out that we certainly look for all the things that we can do before we have to get the surgery. And I know that may seem counterintuitive when you're talking to the surgeon, but our interest is in finding the thing that's going to help the patient in the best way possible, and it meets their needs and fits their life and their goals. So my name is Roddy McGee. I'm a board certified orthopedic surgeon, and I'm have a subspecialty in sports medicine. This is my 14th year in practice in Las Vegas, Nevada. I'm proud to say that we've had patients travel from 42 states and 17 countries for care in our practice. It's been a big privilege of mine in my career. A lot of them centered around the orthobiologics that we're going to be talking about. But now that we've been doing a more innovative approach with knee replacement, we're getting a lot of patients travel for that as well. So I've done over 1,000 knee replacements and over 1,000 biologic injections. That'll be the two main focuses of the discussion. So that's not Bill, that's actually my son. But I'm going to show you Bill here. Bill is 85. He's a pickleball player. He had knee replacement about a year ago. Very active. This is a video taken 6 days after his surgery. And you can see he's not using a cane or a walker.
Here's Bill. He's 6 days post total knee replacement, and he is moving remarkably well. So we're really happy to see his progress.
So Bill had a really terrific outcome. We were really excited to see how well he was doing. And that video, as I said, was 6 days after his surgery. He was not using a walker or a cane. He was not taking pain medicine. And he's gone on to do really well. He's returned to playing pickleball. I asked him how long he used his walker after surgery. He said for about 15 minutes. So obviously this isn't every single case, but I like to show people what's possible so that they can see when an 85-year-old guy who's, given he's pretty active, but he can move that well and have that easy of a time after a surgery where we take a saw to his femur and his thigh, his shin bone, and it's big open surgery, obviously. But the newer techniques give us the opportunity to move very quickly through the early recovery phase. So has anybody been told that surgery is the only option for them? And I'll share with you my two least favorite statements that patients come in very often to our office. One, they're told you need a knee replacement. So the first thing I say is nobody needs a knee replacement. This is an elective surgery. It's something that we consider and have a discussion about when other conservative treatments have failed. And in fact, I don't know if anybody already knows this, but about 30% of the joint replacements that are done in this country are unnecessary. Patients could certainly succeed with conservative treatment. So we want to reduce that number. We don't want anybody having surgery that potentially could get better without it. The other one I like to hear is that somebody has bone-on-bone arthritis. And it's such an overused expression, but the number of x-rays that I see that are not even close to something that you would call bone-on-bone it's surprising. So I tell people, make sure that you're comfortable with the evaluation you're getting and the information you're receiving. And don't be afraid to ask, is there any other options, and see what somebody has to offer them. And I'll share with you what we like to share with our patients. So, we want to talk about medically valid treatment options. We want to talk about that fact that more people are candidates than you might think. And when we do have to get to surgery, now we have options that we can reduce the recovery time. So, should somebody even bother talking to us? Do they have a knee that could potentially benefit from a conservative treatment? Or is it all just a waste and we have to just get right to the business of fixing the knee? So this is what we're going to be talking about, what we want to share. We want to make sure that we have education for people. So what about these regenerative treatments like platelet-rich plasma, bone marrow concentrate, or this whole category of stem cells? And we'll talk about what are the options in terms of stem cells, both here and outside the country, and whether or not any of this stuff even works. Because I know there's a lot of difference in opinion on this, but when you start going to more and more orthopedic conferences and other conferences where we talk about treatments for these types of things, these research papers and physicians all over the world are recognizing the value and the really good outcomes that are surpassing all the other things that we've had in the past, and even demonstrating better outcomes than knee replacement in some cases. And we'll talk about that. So I love this. Well, this was supposed to be, I don't know how to play my video within this slideshow. It's not working, but there isn't one paper demonstrating benefit. There's hundreds of papers. And we'll talk about some of the highlights for that. So let me show you another patient of mine. This is a 53-year-old gentleman. He's a soccer player. He had an ACL injury when he was younger. He's had 8 surgeries on his left knee. I've fortunately or unfortunately for him have done a couple of them related to meniscus tears and arthritis procedures that he needed or chose to go through long after his ACL surgery. We know that patients that have injuries like this when they're younger can develop arthritis easier. So he's in the middle of that. He elected to undergo a procedure that has been studied heavily in France. And this is a bone marrow aspiration where we take bone marrow from the pelvis and we injected the concentrated bone marrow into the knee joint and into the bone. And that's a really important factor because it hasn't been that long that we've understood that a lot of the pain generation is not actually on the cartilage surface, which is what we've focused on forever, but you can have breakdown and stress reaction within the bone just next to that cartilage surface. And if we treat that, you can have a result like this. So this is Kurt. He's 53, and he sent me this video, and he said, I haven't run in 4 years. And, he's not going to be competing in the Olympics anytime soon. But the fact that he got out in his backyard and could run and he had no pain, and he said the pain, the clicking, the catching, all the problems that he was having, they're gone. And interestingly, one of the things that he shared was if I had told him ahead of the procedure that he was going to be able to get the outcome that he's had, and I had told him that procedure was $200,000, he would have figured out a way to get the money to pay for that. That's how valuable it was to him for his activity. He coaches young kids in soccer. He wants to be able to get out there and demonstrate different things on the field with them. And now he has that ability. So he's really appreciating how well he's done. And we're also excited for him as well. So we're talking about a couple of different things. Bone marrow, in that case, the stem cells and growth factors that are a part of that. Another popular biologic treatment that you may have heard about is called PRP, or platelet-rich plasma. This is where we draw blood, we spin it in a centrifuge, and it separates by the components. We take the plasma, which is rich in platelets. A platelet is think of it as a protein that creates and forms a clot when you get a cut. Well, it turns out there are also other growth factors, or again, think of them as little proteins that create signaling that help with inflammation and pain and have a very good track record with knee arthritis. So this is what we do. We inject it into the knee, and in a pretty short amount of time, some patients within 2 weeks, some it takes us up to 12 weeks, but there is a significant reduction in the pain in the knee as a result of that procedure. So how do the platelets and the stem cells work? What they're doing is they're reducing inflammation, they're reducing swelling. That helps the joint move easier, and it's protecting the cartilage from breaking down further. So when you have cartilage loss in the knee, there are proteins that increase as a result of that, and those proteins then cause further breakdown of the cartilage. when you inject either stem cells or platelet-rich plasma, it reduces that protein level, and then it prevents that protein from breaking down the cartilage further. And what are we talking about when we talk about stem cells? So there's a couple of different sources. We've already talked about the bone marrow. We have talked about platelet-rich plasma, which technically is not stem cells, but another biologic agent. There are stem cells in our fat tissue. It turns out we can harvest fat from the abdomen. And this was my first introduction to it, was this idea, listening to a talk in 2012 where they showed actual growth of new cartilage. And we'll talk more about that in just a sec. Other options are something called Wharton's jelly, which is a substance that's inside the umbilical cord, that can be prepared from a young, healthy mother that has donated tissue after a C-section. And then some of these sources are not allowed in the United States. There are some changes in the law in Florida. And then we have connected with a couple of clinics that are outside the United States. We have one in Roatan, which is an island off of Honduras. And then we have a new clinic that will be opening soon in the Bahamas. So there we can do some things that are not allowed currently in the United States. And the one thing that I do want to mention is that currently there is no treatment that grows new cartilage. And anybody that's saying any of these things can do that is being irresponsible with their description. So we can improve pain, we can improve inflammation, we can get an excellent outcome with these treatments for the right patient. But we are not growing new cartilage. That may be coming down the line. I haven't seen anything yet that tells me that that can happen and is easy to reproduce. So a better term, actually, also for instead of stem cells, is orthobiologics. Technically, there was a time when we believed that we were injecting cells that were turning into tissue, in terms of like a tendon tear or turning into new cartilage. We now know that that's not what's taking place. We are creating signaling within the body, and that's helping with pain, inflammation. So far, there are some small studies showing the potential for tissue regeneration. Again, I don't know that that's reproducible yet. And so anybody talking about that should be very careful with what they're suggesting. So why do we use these in Las Vegas with our patients? It's frankly over a decade of experience. We're people pleasers. We like happy days where patients come back and they're doing well. They like us. We're celebrating that they are returning to their activities. We want to make people happy. And so when we find a tool that can improve symptoms, that frankly patients are telling us, I've tried everything and then we did this and the result was very different. Now I'm able to resume my activities. I'm very happy. My pain's gone. We like having those days. So we started using these more than a decade ago. We've had a lot of success. We try to be very careful about who we recommend, and we try to be very appropriate with what's called the indication, or we match the thing and the problem with the treatment. So we're not just throwing this at everybody and saying it can do anything. There's certainly patients that we say, look, this is an option, but either we're trying it knowing that we have a lower chance to do well, or we just really need to move on and think about other things. And in that case, we're talking about knee replacement. We now have techniques, and we'll get into this shortly, that can help make that recovery even easier. So there are costs with biologics. They are not covered by insurance. Their surgery or orthobiologics, there's going to be cost. And whether it's a deductible or the cumulative cost of your doctor's visits, the physical therapy visits, any of the time lost, these things all add up. There's certainly a longer recovery time with surgery. There's more risks. You have the risk of infection, anesthesia, blood clots, the need for additional surgery. Very little in terms of risk when it comes to an injection. So sometimes those are the things where we lean towards it, especially if somebody's not a good surgical candidate, if they're older, if they're not as healthy, or if the patient just chooses, look, I want to see how well I can do before I have to consider going through a big surgery. These are all good ways that we've found patients to get significant relief and something that endures. So the average benefit with any of these regenerative treatments can be anywhere from 1 to 4 years, and that's documented in the research. So you're more likely to qualify than you might think. I've seen some very terrible x-rays that you would think have no chance to respond. But as I said, in certain circumstances, somebody may not be a good candidate for surgery. It may just not be the right time for surgery. So I had a particular patient. You would say his x-rays looked like end stage arthritis. And it did not look good. We had the discussion. His wife was about to have a surgery, so he couldn't go through a surgery at that time. And he just wanted to know, what are my other options? Is that something that I can consider? So we had the discussion. We decided to try a PRP injection. I just saw him back 4 weeks after his injection, a gentleman that has an x-ray that a lot of my colleagues, frankly, would probably criticize me for even trying this or suggesting it. But again, he was in a situation where it was something he wanted to try, see how he could respond. And again, he wasn't ready for surgery. He needed to help his wife. At 4 weeks, he said he essentially had no pain at all. He's moving around well. He's able to help his wife with her recovery, drive her to her appointments and her therapy. And so we don't know how long it's going to last him, but at least for the time being, that was a big victory in his life. So let's just get to um, in order to find out if you're a candidate, we need to evaluate you. We need to find out what are the demands that you have, what are your goals, what are your images look like, what does your physical exam look like, and then we can talk about options. And that's the nice thing about my job, frankly, is I'm not pressed in many cases to tell somebody they have to do one thing or another. We have options. We can talk them through. We can decide what somebody wants to and is willing to go through. And these two aren't the only other things too, right? There's oral anti-inflammatories and there's other types of things we can inject. There's physical therapy and other soft tissue work that we can consider. We have lots of options. We can talk it through. We can go through it together. And we can have shared decision making in terms of what we want to go forward with. So if you do need a surgery, does it mean that you're going to be stuck in bed? Probably not. That's the great thing. The hard thing for me in my career with knee replacement was the early recovery. I used to tell patients all the time, there's going to be part of the beginning of this where you say, I don't know why I even did this. And I just want you to get through that part because soon after, almost everybody says, I don't know why I waited so long. Well, now that difficult part, it feels like we leapfrog through that and people get right to almost to the second and other intermediate steps of the recovery. And it's been just a lot nicer. And we'll explain some of that in just a second. So this is, as you may have heard, the Jiffy knee, which obviously is a silly name. But what isn't silly is the results and the recovery. And it's one of the biggest changes in anything in my career. So the bottom line is we're preserving the muscle and tendon. It makes it a less invasive surgery. It's still a big open surgery. It's still invasive. We're making saw cuts on the bone. We're putting the implants in. But the difference in the recovery has, for me, been remarkable. So this kind of shows you the approach. If you look here, there's a black line following along the kneecap there. That's called a parapatellar approach. That's what I did my whole career. There's some patients that recovered really well from it, but a majority of them had quite a bit of pain and they moved slowly in the beginning. Now, if you look on the picture on the right, our approach really only moved over about 1 inch. If you see the edge there of the capsule going to I don't know if you can see my cursor on the webinar, but the corner there of it's called the vastus medialis, which is this muscle next to the kneecap. When we go underneath that, the recovery is just significantly easier. People don't lose as much muscle in the early going. Their strength and their ability to walk is much greater. And the nice thing is we just moved the incision over slightly. And a result of that, which it made me think, like, why did I not figure this out long ago? There's no tension on the wound when you bend your knee. And so people don't back away from bending in the beginning. And so they get their motion earlier. They don't lose their strength. They're able to stand and walk around much quicker without having to use an assist device. And the whole process has been made easier. So, we do a lot of things with biologics. We have innovative surgical techniques. There's times when we're combining these ideas with our different surgeries. And the whole idea is, what's the way to get patients the best outcome? How do we get them through these things as easy as possible? And there's a lot of value in that early recovery period and skipping through portions of it that have significant pain and need a lot of pain medication. So we have a lot of good evidence supporting the different treatments that we're offering. We have story after story after story. I mean, over a decade of patients that still continue to come to us from far outside Las Vegas. It's a lot of fun when you've got good tools, you've got nice ways to take care of people, and you help them through some of these problems. There's a lot more people that have the opportunity to benefit from any of these things, whether it's biologics. If you're not a candidate for biologics, or it's not part of the process that you want to go through, then we have nicer ways for people to get through recovery after knee replacement. And now surgery doesn't mean long, painful recovery. So again, preserving the muscle, it's a significant difference. So, in 6 months, something that's been a problem for a long time could be in the rearview mirror and be back to doing things and not thinking about a knee. So there's not really any right or wrong thing. We're not particularly trying to send a person down a particular path. And that's what I like about the position that I'm in, is I have the training and the ability to help somebody with a surgical option, and somebody that either wants nothing to do with the surgery or doesn't even need to be a candidate for surgery, with lots of good options that can help them get better without it. So that's a little bit of you know what? Hang on. All right. So got a little confused on my slides there. So what are we talking about? When you come to see us, we're going to take a detailed history. We want to get to know everything about you and what's going on. We're going to review labs. We're going to take time with one of our providers, me, or we have an outstanding team, go through what the options are, discuss which way you want to go, and see what can be helpful. And we're going to create the roadmap to help somebody get better with all of the elements. We want to utilize all of the research and evidence that helps each step of the process. So right now, we're, for the folks that have joined us on the webinar, we are creating a priority scheduling for anybody that wants to talk with us more or has more questions, and we'll have time for questions here in just a minute. We'll create a custom plan, and then if it's information you're looking for, if you'd like us to take you through any of the treatments, obviously that's what we do. That's our knowledge and skill, and we're happy to share that with anybody that needs us. So most of the time, a consultation is covered by insurance. Some of the treatments are out of pocket, and some of the things that we do are certainly within your insurance. You can scan this QR code. You can go to this page, vegaskneerelief.com, and you can access that. We'd be happy to schedule anybody, and also happy to answer any more questions that people have tonight. And I really appreciate everybody joining us. So a couple of the questions. Some of these things can be a little bit expensive. Is it really worth it? Really, it's a discussion for us to have. If the cost is really prohibitive, we do have a couple of different options for ways that we can still achieve that with our patients. Ultimately, it's comes down to what is the value in terms of time and in terms of the things that you want to be able to get back to, and it's something that we can talk through and decide together. So somebody's very old, or is their knee too far gone? Like I said, there's evidence supporting even very severe knee arthritis can benefit from orthobiologics, a simple injection. Some patients are worried, hey, I'm too old to go through a surgery. We've had patients in their mid and upper 80s, even into the 90s, that have gone through surgery successfully. We obviously have to do a medical evaluation to determine if that's appropriate. But we can have these discussions, and there could be things that are very simple that have very little pain, but can produce a significant relief in terms of the pain, what's going on. So somebody that can't afford the downtime, some of these things are very rapid recovery. And again, it's all about matching up the right thing for the person. This is a topic that comes up time to time, is people want to know, well, if it's not covered by insurance, it must not be any good. Or why is insurance saying that this is experimental? And I can only tell you that the insurance company isn't searching for the best outcome for you or the best option. They're looking for the thing that keeps the money in their account the longest. Is our orthobiologics experimental? I don't think we can say that at all anymore. There's hundreds of research papers. We've been looking at this and studying it for over a decade. We have, again, more than 10 years of experience of happy patients that continue to come back to us for other injuries, if they need kind of a tune up because they're starting to get some symptoms again and they know they've responded. And just a quick note on that, does it really work? I mean, I've had injections in both of my shoulders with Biologics. I'm able to work out 3 days a week. I don't have any pain. I don't have any limitations on what I can try to do. And so I've personally experienced it. So any other questions, I'm happy to answer. And again, I really appreciate any of you that have joined us tonight. So again, here's the QR code, and vegaskneerelief.com is the website. And thank you. Now, the only thing I might need a little help just to be sure that I can view the questions if anybody has any. So let's see,
You just click that Q&A question mark, you'll see the chat where people are dropping
Okay.
questions. We've got a couple of
Got it.
questions so far.
Ooh, yeah. Okay, so the first question from Mary, thank you very much. You had a knee replacement. You worked very hard on your physical therapy and still having pain. There's still some good options. We work with some really good physicians that are experts on when somebody needs a revision, and we can evaluate things or we can connect you with one of them. But the first step is, check the X-rays. I don't know if this has already been the process with your own doctor that did your surgery, but X-rays need to be evaluated. Everything needs to be checked out for the possible things that can be problematic after a knee replacement. And then there can be still like a sequence of steps starting from simple to more complicated to help get that improved. Marie has a question if our consultation is done over the phone or in person. If you're in Las Vegas, we can schedule you in person. It is a typical, physician appointment. And if you're from out of town, we can arrange for either telemedicine or just a phone call consult. So happy to help if you would like to. Another Mary. So Mary's husband feels she may not be a candidate for Jiffy knee because of being bow-legged. So in the bow-legged, the term that we would use is a varus knee. And if there is a significant angle to that, it's possible that it may be, you may have to consider another surgical approach, but I'm not sure actually that that's a contraindication. It really just depends on what those images look like. And we can easily take a look at that and say, okay, this is a little bit more complicated setup, but it would really have to be significant to be thinking that we couldn't do and by the way, it's called a subvastus approach. And that just means that we're going under the vastus medialis muscle. But that's, yeah, I'm not sure, Mary, he still may be a candidate. It would be just a matter of reviewing the x-rays, but I appreciate the question. Susan says that she has bone on bone that's lateral. And yes, so I would say a varus knee, which is the bow-legged, or a valgus knee, which is the knock knee position. It's still possible through the subvastus approach. A lot of our patients have lateral knee or osteoarthritis, and it's just a little minor adjustment in how you make the cut to get the alignment correct. And it can be corrected. And if that's the only answer and none of these other things are options, then yeah, you would certainly still be a candidate. So, but again, it's a matter of reviewing the images and doing the exam and then considering all the other factors as well. But yeah, that by itself is not a reason that you would not be a candidate for Jiffy knee. So another question or statement also from Susan, thank you. What I didn't mention is gel injections. Gel injections have a long history and they're effective for the more mild arthritis degrees. So, grade 1 or 2. The higher grades of arthritis have not traditionally had as good a results with gel. Steroid injections are certainly an option. They're cheap, they can benefit, and I've given them to many, many patients over the years. The overall, the lasting relief is quite a bit less. The average is only 6 weeks. Certainly, I've had patients that have had benefit for much, much longer than that. But when you look through the research, the time of relief is quite a bit shorter, certainly than either the gel or PRP or any of the stem cell options. So, um, so Keena is asking, how do you know if you're a candidate for a steroid injection? Almost anybody that has inflammation in their knee or has a degree of arthritis and has symptoms from it, there's nothing wrong with trying a steroid injection. We have leaned towards some of the other treatments, and mostly we were talking about things tonight that we thought people may not have familiarity with. But as I said, when we talk with patients, we go over all the options. Um, all of the things are possible unless there's a direct reason that we could not offer that. Some patients that have, for example, very unstable diabetes, a steroid injection could potentially raise their blood sugar and create a problem with that. If they had an allergy for some reason to any of the components of the injection, we have to consider that. But how do you know if you're a candidate for steroid injection? If you're having pain, swelling, and it's related to arthritis, that's a typical patient that we would do a steroid injection. We have plenty more time, so if anybody has any more specific questions, happy to go into any more details on any of the steps. So Susan saying that she was told as long as a steroid is working, there's no need for surgery. I would say if you're getting relief from any of the options that are conservative, then we're not even starting the discussion about knee replacement. I mean, it's a permanently altering surgery that's, replacing the surface with metal and plastic. If anything's helping, then yeah, there's no need to jump to surgery. Um, if somebody's getting relief with Tylenol, even if their x-rays look terrible, then, great, that's a victory. We try to do the thing that is the least risky and gives somebody the most relief. And of course, we want short-term relief. We want to be protective long-term as well. And so we weigh all of these factors. We consider all the options. Other things that we haven't gotten into too much tonight, there are anti-inflammatory sleeves. So there's been research on germanium infused fabrics that give a lot of relief. There is infrared light. So there's laser therapy that shows a lot of promise with knee osteoarthritis. We have a lot of success with if somebody's very bow-legged or very knock-kneed. There's something called an unloader brace, which does very, very well. And mostly the issue is that at some points, people get tired of wearing a brace. And that's really the only knock on that. Otherwise, a very effective treatment. So lots and lots of options. We went through, again, a couple of things that are a little more innovative, a little bit newer, but we don't steer away from the tried and true things that have been around a while. We just want people to know where those fit in, what has the longest lasting effects, and again, try to match it up to the right thing for the right person. So the question from and I think it's Sherry. I hope I'm saying it right. The time to schedule surgery after the consultation. Currently, it's about 4 weeks. Usually, that's the amount of time we need to get any blood work done, any medical evaluation. If somebody needs a cardiology evaluation before what's considered to be a bigger elective surgery, if they have any history of that, it takes about that long to get all these things organized and then get time on the schedule. But I know some of the docs around the country, very long wait times, 6 months plus. We don't have that long of a time frame for scheduling so far. So I hope that helps. And then Rhonda wants to find out about meniscal implants. So my sports doctor uh, has said they can succeed, but mostly in athletes 35. So a question about, I think the question is about a meniscal transplant, which is where we take a meniscus from a cadaver for a patient that has completely lost their meniscus. So the things that have to be in place for somebody to be a candidate for that is no meniscus, pain in the knee, but still relatively preserved cartilage. So if you have a very significant amount of arthritis, you're unfortunately not a candidate for a meniscal transplant. Um, so because essentially we put that implant in or transplant that tissue, and if there's already arthritis, it's just going to break down and not last very long. The idea behind a transplant is to do everything possible to preserve the knee joint for as long as possible. So I hope that answers the question. They typically are, I don't know if 35 and under is a hard cutoff, but they typically are, it's a procedure for younger patients. So an anonymous guest says, if PRP didn't work, would stem cells still be a good option? Very long answer to that question. So the first step we want to evaluate is lots of patients are told that they've had a PRP injection. And my question would be, I'd like to know a lot of details about what happened in that PRP and why it didn't help. So how much blood was drawn? There's something called a recapture rate. So different equipment does a better job of preserving and keeping as many of the platelets as possible. And ultimately, what we want is a very high dose of platelets. It's looking like for knee arthritis, we want above 10 billion. In our practice, we actually draw your blood, we can test it in the office, and we can test the sample of once we've prepared the PRP, we can test to see what is the dose that we have because we know above a certain dose, we have a much higher likelihood of success. So the first answer is, what type of PRP did you have? And was it done as well as it could be? Because you may still benefit from PRP. Could stem cells still benefit? I would say definitely, because what we know is stem cells, at least in the context of bone marrow stem cells, those have 20 times the growth factors as PRP. So you still could be a candidate. We would talk through all of the options and review the images, and then we could make a good decision together. Should I use a sleeve while playing pickleball? Yeah, there's two companies on the market. One's called Incrediwear and one's called Repairl. They're both, I think they're made in the same factory in Chico, California. But they have good evidence for this. You could try that and see if you like it. That's ultimately what it comes down to. Bone spur. This is Mary's question. She has a bone spur on the outside of the knee that pushes on a nerve. Could this be treated with a less invasive procedure? So the answer is potentially. And again, Mary, that would be, we just need to see the images and the overall picture and then talk about what the options are and game plan that. Potentially is the answer. And it may need more than just something basic. But I would need a little more information and to be able to answer that well. Rhonda wants to know about germanium. Germanium is a superconductor. So think about like the Tommy Copper stuff. Copper is a conductor, and germanium is a superconductor. It increases blood flow when a fabric is put on the skin and improves pain and inflammation. I used their glove after a hand surgery that I had. I had carpal tunnel release, and it was pretty wild how I was having, achiness in my hand, and I would put this glove on and immediately it would get better. So that was my own personal experience. Covered. So Delora is asking, is this covered by insurance or out of pocket? When we're talking about stem cell therapy and PRP, those are out of pocket expenses. If we're talking about surgery, typically for patients that have an indication for knee replacement, that is a covered benefit. Dario, I hope I'm saying that correctly. Best options, procedures for bone on bone, no cartilage situation. So again, I've seen very, very bad x-rays respond to very simple treatment. It really depends on the person the amount of pain they're having, the amount of demand they have. And so we kind of walk through, what have you already tried? What are the other options that are left? And then what do we want to go through next? And if something looks like, boy, there's really a low chance of this, then, I would advise you on that. And then we can talk about, what our next steps are. Any colleagues in Arizona? Marlene. So as far as Orthobiologics goes, my good friend Ash Goyle, he's in Scottsdale. He is a anesthesia pain management expert and does a lot of orthobiologic injections, and he's a fantastic guy. As far as surgeons that do the Jiffy knee, Dr. Kavanaugh is in Arizona. He's really, really good, very busy. And so a lot of good options there. I actually do have a license in Arizona. I am a part of a practice that's in Mesa, and there's opportunity for patients in Arizona to see me there as well. So we can talk about that at any point in a consultation. So Susan asking, do you do surgery just for better movement, although not in real pain? Surgery, especially knee replacement, there are surgeries specifically for increasing motion, but if somebody's main problem is stiffness, then I would certainly exhaust all the options before we got to surgery. Another question from Sherry. How far are you scheduling? 6 months with other providers. Yeah, we're probably within 4 to 6 weeks, I would say, Sherry. Tony Johnson, how about genicular artery embolization? So great question. I've been hearing more about this. There's a couple of procedures, both for temporarily addressing the genicular nerves, and there are the embolization procedures. So I don't have as much experience with that. I think that's more done by the interventional radiologists and vascular physicians. I understand that there are options in this way, and we would have to ask some of these physicians about it. My general feeling is I don't like messing with nerves and blood vessels, but I could be shown to be wrong, and this could be an excellent option. I'm not an expert on it, however, so I'm sorry, Tony. Does surgery have the best long-term outcome? So great question from the anonymous attendee. And thank you for asking. So there was a study looking at patients that had knee arthritis in both knees. This was done in France, and this was related to stem cells. So on the one knee, the patient had a stem cell procedure. In this procedure, they specifically injected the stem cells into the bone, and it was determined in a previous study that injecting into the bone, especially in patients that had evidence of bone breakdown on MRI, that long term, they had a very low chance of going on to needing a knee replacement. The same group, and it's Dr. Hernigou, Hernigou, they studied this and they looked at patients with knee arthritis in both knees, one knee treated with bone marrow stem cells, the other knee had a knee replacement, and they followed these patients for 10 years. At 10 years, 77% of the patients actually preferred their bone marrow stem cell knee to the knee replacement knee. So that was pretty remarkable. Knee replacement is a wildly successful surgery in this country, no matter how you do it. There's more than 500,000 knee replacements done every year. The complication rate is very low, thankfully. The complication possibility is very real, however. So we are aware of that. We do everything possible to minimize it. The biggest things would be blood clot and infection. Those are the most devastating. We certainly try to minimize that. It's extremely rare, thankfully. But there are patients that have an approach in their mind that, hey, anything that's not surgery, I want to see how that does and be sure that isn't something that can help me before I then go consider a surgery. And I have another set of patients that their general feeling is, I just want the final thing. I don't want to find out and spend time and energy, potentially money, on something that, and I'd just be disappointed if it didn't work. And so I'd rather just go through the surgery and know that, okay, now I'm done with it. And hopefully I'll get the perfect outcome that we're all striving for. So it's a great question. Does surgery have the best long-term outcome? It really comes down to what is the degree of arthritis in the knee? And what is the person's demand? What are their goals? And so there's no perfect answer for that. So in some of the studies, the biologic injections have had better outcomes. For some patients, a definitive final answer is better for them. So the nice thing for me is, we have the ability to walk through it with you, try to provide the thing that is, best for your situation. And I'm not particularly slanted one way or the other. I'm just here to help in the way that fits the patient best. So another question, and we've got a few more minutes. So does Jiffy knee surgery only have to be done once versus knee replacement needs to be replaced in about 15 years? So good question. Our knee replacement techniques and the materials are getting better and better, particularly the plastic that's the insert between the metal. Um, there, knee replacement that has to be redone in 15 years, it's not necessarily the case. There's evidence of 20 and 30-year longevity in knee replacements now, particularly, again, better techniques, better implants, all that type of thing. So the risk of needing a revision is the same in the Jiffy knee as it is a standard knee replacement. It's a thing that we all have to be aware of and do everything possible to minimize. Loosening of the implants is possible, but again, the wear of the plastic is much longer now. The techniques for alignment, all our instruments are much better. So 15 years it's a number that gets thrown around a lot, but it's not necessarily, there isn't necessarily like an endpoint. Any other questions about any treatment for knee arthritis or options or anything like that? Is the only difference between traditional knee replacement and Jiffy knee the location of entrance? Same internal process. Great question from Stephanie. The difference in Jiffy knee is related to the incision and the surgical approach, or it's called the arthrotomy. It's how we enter the joint capsule to expose the knee. Once we're there, all of the steps are the same. It's the same thing that I did when we would cut through the quad tendon to move the kneecap over and expose the knee. But the difference in recovery is significant. Now, does the other way work? Of course it works. It's worked for 30 plus years. It's just in my experience, the early recovery is so much easier for the patients. It's hard to go backwards and go back to the older techniques when you see somebody have it so easy. So Susan, if steroid is working approximately 10 weeks, would there be a reason to try PRP? Well, if the steroid is only giving you 10 weeks of relief, the concern would be, are you going to get a steroid injection every 10 weeks? Like that's going to be 5+ per year. That's more than the general recommendation. There is some systemic effects slightly. There is some cumulative effect, and over time, more and more steroid exposure potentially harmful. So would there be a reason to try PRP? Well, the outcomes in PRP show 12 to 48 months of relief. So potentially fewer trips to the doctor, I guess, and really a treatment that has no downside. It's coming from you. There's no chemicals. There's no side effects. There's no systemic effect. It's just benefit to the knee. So a little more natural approach, using your own body's harnessing its own healing mechanisms. Tony wants to know how long before you can fly home. Depends on the length of the flight, and so that would, if it's short, potentially a few days to a week. The concern would be for blood clots. So we would just have somebody on a blood thinner, and we would use what's called a sequential compression device. It's a little leg squeezer that moves the blood in the lower leg and also releases a protein into the bloodstream that decreases the chance for blood clot. But we would want to be as safe as possible. And if it was a lengthy flight, we could potentially be waiting 10 to 14 days. Shorter trip, then we can consider an earlier takeoff. So we got about 5 more minutes, and happy to keep going. So Keena, does having all surgery make you a candidate for arthritis? All surgery or ACL surgery, I think might be the question. Patients that have had ACL surgery have a higher risk of arthritis in the knee. Now, some of these biologics, if done either at the time of surgery or in some time frame after the surgery, again, it can be protective of the cartilage that's in the knee. So if somebody has no cartilage loss, it's potentially preserving all of their cartilage. If there's minimal cartilage loss, we want to prevent that from getting to the intermediate and severe stage. And PRP and stem cells both have a track record and a mechanism that demonstrates that that's possible. A friend of mine that's in New York, he actually is bold enough to say that he wants to prevent all knee replacement by 2043. And so 2043 is that's about 18 years from now. So essentially saying any patients that have no or mild arthritis, if in this time frame we can have them on a regimen of protecting their knees with orthobiologics, then potentially we don't have to replace anybody's knees. And that would be, pretty cool if we were able to kind of greatly reduce the need for it. Because again, although a high percentage of them do extremely well, the ones that have to go through complications, it's a lot to deal with for all of us, both patient and doctor. So another question, if I had knee replacement surgery and still have some slight pain, would I be able to benefit from orthobiologics? And, the answer to that's definitely. The question would be, where's the pain? What's going on? And then what are our options? So we've had lots of patients that, for example, older patients that there's no way they're going to consider a revision surgery, but they're having some pain. That's where we've been able to take advantage of our, it's called an MLS laser. This is infrared light therapy that decreases pain and inflammation. And they've done extremely well. This is a thing where you lay down for 10 minutes, and our program is 12 sessions, but that would be a couple of times a week. But you literally don't feel anything other than you feel better after the light treatment. It's infrared light. It penetrates the tissue deeper than red light therapy, which you may have heard of. But that's been a very effective, non-invasive option. And so, slight pain could be addressed very easily with a number of different options. Again, it would depend on what's the pain generator and the source, where is it, and we can evaluate that and then address it in that way. So we got about 2 more minutes. If anybody has any other things, happy to share. And again, I really appreciate all the people that attended, and thanks for all the great questions too. And are there any supplements that are truly helpful with knee pain? Good question. There's a lot of interest in glucosamine and chondroitin. There are some big studies that show some promise with that one. Some of the other different things, different kind of cartilage replacement supplements I've seen, they just don't have a big enough number of patients that have been studied to know if they can be of any benefit. There are supplements that we know help with recovery and protecting and restoring the muscle, both after surgery or with any other type of treatment. And that it essentially comes down to the branch chain amino acids. And there's a couple of other things. So there's a couple of different companies have some things like this. One is called Accelerated Recovery. Another is Complete Surgical Nutrition. And another company is called Mend. And they have a number of different blends that have some of these things that can be beneficial. As far as just supplements for arthritis pain, we could certainly look at things that have sort of a plant-based anti-inflammatory approach, any type of anti-inflammatory diet as well. So no harm in any of those things, and it would just be a matter of how well does somebody respond to that particular thing. So thank you again for all the questions and for your attention tonight. It's 8 o'clock. I'll let everybody go on about their night. If you have any further questions, please feel free to contact us. Thank you. Oh, wait, we had one more, Jody. I'll get your question and then we'll be done. So bone-on-bone arthritis, bone spurs. She's tried Wharton's jelly and it did nothing. So very disappointing. I would just say, Jody, we would need to evaluate your x-rays. We can talk about options to see if any of those other things that we have. I'd be interested to just know, like, and understand the dose, the source of where you got the Wharton's jelly, where they injected it. And then we could talk about what possibilities there could be. There might still be some things that aren't surgery. And it would just be a matter of discussing what we can try and how. But potentially there are some biologic options that we could consider before surgery. Okay. And Marlene, thank you as well. Everybody have a good night.